following the course on Monday, complete your post-course surveys as well. So with that, I'm going to leave everyone to it. We're going to start with, I said, our guest lectures from our esteemed colleagues in Denmark. And I want you to now meet one of them, Jan Hartvigsen. Jan is a very good friend and colleague. We've worked together for many years. And I don't think there's anyone who's more accomplished in the field of low back pain research than Jan. He has been on numerous guideline committees, the most recent at the WHO. And I don't think he'd mind me telling you either, because of his work in this, he is a knight in Denmark. He is actually a knight, and we're in royal company as a result. So with that, I'm going to just turn it over to Jan, who'll be talking to you for about an hour on just the latest and greatest in low back pain research and how this is used to inform what we do in the GladBack program. Take it away, Jan.
Well, thanks, Greg, and thanks for having me. I don't know how you even give a talk after that introduction, but I'll try my best. I'm speaking to you from Denmark, hence my accent. I hope you understand what I'm saying. It's 20 minutes after 4 in the afternoon here on a beautiful fall day. So day's almost over for me, but it's just beginning for you. I'm gonna share my screen with you, and I hope you can see my slide here. This is a picture taken outside of our building at the University of Southern Denmark, where I work, and I co-lead the Center for Muscle and Joint Health. And as you can see, there are a lot of very enthusiastic people working there. I think we must have gotten a big research grant on that day or something. But we're a multi-professional center, and we are around 50 researchers working together on a range of projects in musculoskeletal health, with a strong focus on translating evidence into practice, and a strong focus on physical activity, patient education, and exercise as interventions to promote general health and musculoskeletal health. So my talk here is really to try to establish a common foundation for all of us, so you have a better idea of why the GladBack program looks like it does today, because it has evolved over time, as all dynamic things should. It's not a static program. And so I'm going to touch on some key areas in back pain where our understanding has changed in recent years. And where I would really say we are in the middle of a paradigm shift in the way we understand back pain, the way we understand the impact of back pain, the way we understand diagnosis, and the way we understand treatment and management of people with back pain. And why are we in the middle of a paradigm shift? I think that is captured with this single slide. So I just typed in the words back pain in the database PubMed, and this is what came out. You can see that for the past, 175 years or so, the number of papers, research papers dealing with back pain was, mostly very, very low. In fact, the first paper I could find in the database was from 1912, and there was one paper on back pain published that year, scientific paper. But you can see in recent years, we've seen an exponential increase in the number of research papers that, respond to these search terms, back pain. And really, with this enormous amount of research coming out, it's only natural that our understanding of back pain is changing. It's changing with evidence. And that's a change from previous paradigm shifts in back pain that have changed mainly because of opinions of people. Now we have much better evidence foundation for our practice, and we are learning new things all the time. Last year, we saw around 8,000 new papers in PubMed dealing with back pain. And so far this year, I put this number in a couple of weeks ago, so it's likely a little bit higher, but we have We've had over 4,000 new papers published dealing with back pain. So it's no wonder that we are learning new things every day about back pain. So it's a very exciting time to be a back pain researcher, but maybe even more exciting time to be a back pain clinician, because the world is changing, and that's always exciting. So touching on a few key areas in relation to back pain. The first one is about the burden and the impact of back pain in people. And actually, we knew there was a lot of back pain out there, but with the Global Burden of Disease study and other high quality studies of the prevalence, the impact and burden of back pain, we're actually seeing that it's worse than we thought it was. First, to your reading left here. So I'm originally trained as a chiropractor in the 80s, and I was told that children did not have back pain. Back pain was something that came on when you entered the labor market. You got exposed to all these lifting and bending or whatever, sitting or whatever you did, and gradually you wore out your back, so the prevalence and burden of back pain increased with age. But what we can see is that back pain is already common in childhood. That's fairly new knowledge. It's only about 15, 20 years old, 10, 15 years ago that we realized that. Throughout life, women report more pain than men. But really, it starts early and it's with you for your whole life, at least if we look at the population. If we look at disability for back pain, on your reading right here, we see a comparison here between 1990 and 2015. And you can see the red bars here being 1990 and the blue bars being 2015. And what you can see is that throughout the lifespan from around the age of 5 to over 80, the blue bars are taller than the red bars, meaning that disability has increased over those 25 years. And in fact, if you add it all up, disability has increased with more than 50% in just 25 years. This has mainly been because of aging populations and population increase, but the global burden of disability is not getting smaller, it's getting bigger. So what will the future look like? This is something we looked at last year and published in a journal called Lancet Rheumatology. I was part of publishing this paper. It's a little bit difficult to understand this figure, but let me explain it to you. Up here in the corner, you see the number of back pain cases, people living with chronic back pain in the world from 1990 up to around 2020, where we have the last numbers from. And then we do some computer modeling where we model what will happen between 2020 and 2050. And we're projecting a steady increase in the number of people who will live with chronic back pain. Now, what these green and yellow bars are showing you is that this increase will not be equally distributed around the world. So, for example, in Western Europe, where I'm at, the increase will be fairly small. Now I can't find North America. It's in here. Some high-income North America. That's where you're at. You will see a somewhat larger increase than we will see in Europe, around a 20% increase in cases with chronic back pain. But look what it looks like in Africa, Central Sub-Saharan Africa, Eastern Sub-Saharan Africa, and in South America too. You will see a very, very large increase in the number of people living with back pain as these populations get older. And that's, of course, why the World Health Organization is now looking at this and saying, listen, we have to do something at a global level to make sure that people receive the care that they need, that we are ready to meet the needs of populations everywhere with rational and good care for back pain. And there's even some evidence that we haven't realized and seen the whole burden yet. Because if we do surveys of the population in my country, more than 50% of workers report that they go to work frequently with pain or recurring pain in one or more body regions. And depending on which setting you're looking at, up to a third of people seek care in primary care for musculoskeletal complaint each year. So while we're not all patients all the time, most of us will be patients eventually because of a musculoskeletal pain condition. And we can't say that about very many other health domains or health complaints or diseases. So the burden of back pain for societies is absolutely staggering everywhere. What we are also seeing now is a shift in the way we look at burden. We look at it, of course, at this societal level, all the big numbers that can be kind of difficult to relate to. But we are seeing an increasing number of papers focusing on what it means to live with chronic pain, focusing on the lived experience. And we now have so many studies that we can publish systematic reviews of these qualitative studies or interview studies, and we can condense the themes that are identified and what emerges if we look at very many interviews with people about living with chronic back pain. They collectively tell us that their life is impoverished and confined. They feel they're struggling against their body. They cannot be themselves. They don't understand what's wrong with them. They cannot explain to their family, their colleagues, their friends why they have this pain, and they feel that they are losing personal credibility. They are losing status in society and in their families. They feel a need to be treated with dignity. That also includes when they meet healthcare professionals. They feel they are not treated with dignity, and they are trying to keep up appearances. And these are really quite profound themes, profound issues in a person's life. And I think this adds not only color, but deep knowledge to the impact of back pain on individuals that really supplements the knowledge we have about the burden for society. So the authors of this paper conclude that this knowledge demonstrates that treating a patient with a sense that they are worthy of care and hearing their story is not an adjunct to care in a way that we kind of have dealt with it now. It's an integral part of healthcare. It's part of the care, listening to the patient, validating their pain, and listening to their stories and helping them make sense of their story, their pain story. It's not an adjunct to that you should get over with so you can do your treatment to the patient. It's actually an integral part of your treatment for the patient. And that is why the patient education part in Gladback and how it's integrated with the exercises is so incredibly important, because it's addressing this directly. Now, we're also learning many new things about why people get back pain and what back pain is. And guess what? Many of the things we thought caused back pain turn out to be wrong. Of course, there's something in the back that produces pain, and there are many structures in the back that are capable of producing pain. But in recent years, we've learned that probably more important than that is what happens in the nervous system. Pain, knowledge about pain, neuroscience, how pain is processed in the brain, and how pain affects our mood, and how our thinking about pain affects the pain itself and how we react to pain. So both physiological processes and cognitive processes around pain turn out to be extremely important, and many times in chronic pain more important than what happens in the back. This is really where cutting edge knowledge about back pain is. It is around pain neuroscience. We're also learning that people with back pain have many comorbidities like asthma, diabetes, mental health problems. They are overweight, and many times they have pain elsewhere in the body, as you will see in a minute. In fact, 2 out of 3 people with chronic back pain have at least one other chronic condition that affects their health, of course, but it also affects their pain. Social factors are tremendously important. People with short education, low income, heavy physical work, and poor access to healthcare have higher prevalence of chronic pain. Depression, anxiety, low self-efficacy, mental health issues greatly affect pain experience and chronicity. And we're also learning that some people just seem to be more sensitive than others. There's an underlying genetic disposition for back pain that ranges depending on how pain is defined in the particular population. But regardless of where we look, it's a substantial underlying genetic disposition. And I'm sure you know that from your clinics, that there are just some patients that seem to be more susceptible to pain than others. And we need to acknowledge that and take that into consideration, of course, when we treat the patients. So from years ago, a few decades ago, when I was educated as a clinician, we learned that back pain is all about having the right chair or having the right backpack, or maybe one leg is a couple of centimeters taller than the other. We are now learning that this is really a very complex condition, and that makes it just incredibly interesting much more interesting to deal with these patients. And it's also why we haven't been able to find a quick fix for back pain, because we try to fix back pain with easy solutions when really it's a complex personal problems, chronic pain for the patient who suffers from it. And I want to show you a slide. This is published by a PhD student of mine, Cecilia Øverås from Norway, where we looked at people with chronic pain in a large Norwegian database that has almost 132,000 people in it, and where they had collected data in 1995, 2006, and again in 2017. And we mapped the patterns of co-occurring pain with chronic back pain in these people. And what's striking, you don't have to be a rocket scientist to see how remarkably similar these patterns are over 2 decades or more than 2 decades in this population. And if we map it another way and see, well, look, only 1 in 10 have back pain only. 9 out of 10 people have pain in at least one additional spot in the body: upper back, neck, shoulders, elbows, wrist, hands, hip, thighs, knees, ankle, feet. And look how similar the prevalence of these co-occurring pain sites is over the decades in this population, remarkably similar. And this is something we're beginning to understand, how pain behaves in the body. And people with chronic back pain probably not only have back pain, it seems to be quite rare to have only back pain. So pain's not just in the back. There are some signals from those receptors, of course, but without the brain and without the nervous system, we wouldn't realize that. So pain and the way we perceive it is a result of pain processing, the attention we pay to the pain, how we interpret the pain, and how we behave and react in response to the pain. And to your right, that's when the person feels the pain and takes action in relation to the pain. So glad back is a whole lot about focusing on this part. How do you think about pain? How do you react to pain? And of course, how can you use exercise to modify pain processing and interpretation and behavior? And of course, also influence signals from nociceptors in order to have a better outcome out here to your right. And it's very important to realize that pain and disability are not the same. Predictors of disability are to quite a low extent the result of clinical findings and what you see on MRI scans, but they have a whole lot to do with people who have low self-efficacy and who have unhelpful beliefs about back pain, people who don't know what their back pain is. We need to become better at explaining to people what's wrong with them, and this is what you will learn in this course, that they don't think they can do anything to get better, that they think movement is harmful. They think there's nothing to be done about back pain. They're very pessimistic, that back problems only get worse, or that they have back pain because they have a weak back, or a back that's not straight, or a leg that's a little bit longer than the other, or they are too tall, or they are too short, or they are too thin, or they are too fat. All these explanations, or they had a disc herniation 15 years ago, that's why they still have back pain, when we know that these things tend to heal, and it's quite unlikely that a disc herniation that happened 15 years ago would cause pain today. And many of these myths and unhelpful beliefs you need to work with in the patient education when you deliver the exercise therapy to to work with the patient and have them realize and understand that these are not helpful beliefs, and most of them are actually not true. We're witnessing paradigm shifts around diagnosis too, and we cannot diagnose like we thought we could. I remember in the 90s, I was a fairly young clinician. That's when we had MRI scans introduced, and all of a sudden, this wonderful new technology, so much better than X-ray. We could open up the body and look into the body and see everything. Say, well, now we can see what's wrong with the patients. And we started to interpret the MRI findings that way because we saw a patient, we saw disc degeneration or facet degeneration or disc protrusion. So, oh, you have pain, you have a disc protrusion. That's the explanation. But after some years, we saw studies coming out where researchers had included people without back pain in MRI studies. And this is one landmark study published in 2015, where you see some of the findings we're looking for on disc herniations. And you can see the columns getting taller because they're a reflection of age. So here's younger people, and here are people over 80. And you can see that some of these findings approach a prevalence of 100% in people, even in people who don't have chronic back pain. So when you have a patient in front of you, you really don't know if their pain is there because of these findings, because you are almost as likely to find these findings in people who don't have pain. So if you ask if an MRI can help you identify patients who respond better to a particular kind of treatment, the answer is really no. Or if you ask if MRI findings can help you predict the future for back pain patients, in other words, inform about their prognosis, that's a very important feature of seeking healthcare. You want to know what's going to happen in the future. What can you expect of the future? You can't really use it for that. There was a very, very good systematic review published just last year where they looked at this again and looked at newer MRI studies, newer cohort studies. And it looks like, at least on the group level, if you have many degenerative findings and if you have modic changes on top of something else, your prognosis is a little worse at the group level. But really, when you are faced with the individual patient, you cannot know if these findings are the cause of their pain. And it's quite a dramatic change in the way we look at the usefulness of imaging for back pain patients. For some patients, of course, I'm not saying we should never do an MRI scan to a back pain patient. It can be incredibly helpful if we suspect an underlying serious medical condition, or if we are referring a patient for surgical evaluation. Of course, it's only natural that the surgeon wants to see an MRI scan because how else could they make up their opinion about whether there's a surgical target? But in most patients with back pain, that's not the case. So how do we think about degenerative findings when we communicate with patients? Well, we have this analogy, and we think it works pretty well. We tell patients, it's a little bit like if you have a cut on your hand, and it doesn't mean that your hand is sick or it's going to fall off or it's weak. It just means you have a cut in the skin. It's not dangerous. But sometimes you're reminded of the cut. For example, if you're cooking Thai food, Asian food for dinner, and you're cutting a chili and you happen to rub some chili on your sore, your cut on your hand, it will hurt. But you know it's not dangerous. It just means you're a little more sensitive. And that's an explanation that many patients can buy and say, yeah, I have a lot of degenerative findings. My back is a little more sensitive, but it's like a cut on my skin. It's not dangerous. It's just really irritating. So you can still cook dinner despite having this cut. I can still use my back despite having these degenerative findings. So maybe that's helpful for you. And I think that's part of the patient education. Another area of diagnosis where we're learning new things is in relation to red flags, almost the holy grail. There's something we all agree on. We have to check for red flags. But guess what? As we do research, it turns out they're not as helpful as we thought they were. A very famous study from Australia, around 1,200 people who sought care from primary care physicians in Australia. They were systematically the doctor systematically inquired about the presence of red flags in these patients, and they found that around 80% of the patients had at least one red flag. But when they did a retrospective chart review a year later, turned out that less than 1% had a specific underlying cause that required some medical action, if you will, to be taken. So these individual red flags are not very informative, but they do contribute to diagnosis of, and they do not contribute to diagnosis of serious pathology, but they do contribute to a lot of unnecessary specialist referrals and a lot of unnecessary imaging. So there's now an international task force led by an international group of people. Prominent researcher Aaron Downey from Sydney in Australia, a good colleague, who are looking at how can we identify better red flags and better indicators of serious underlying pathology than what we're using right now. So that's an area to really follow in coming years, and I know there's some good papers on the way. So looking at the course of back pain, how does it behave once you have it? Well, it doesn't behave like we thought it did. This is, it looks like a really busy and difficult graph, but it's really simple. So with the y-axis, this is where patients seek care. And my good colleague, Alice Kongsted, who you'll meet in a few minutes, has collected results of cohort studies where patients who have sought care from general practitioners, physiotherapists, chiropractors, and who have been followed closely over time, over 1 year. And she's condensed this information and was able to make this graph as a representation of that. And when I say followed closely, it means that they have been asked about weekly about their pain and how it impacts their lives. And usually that's been done through text messaging, SMS. And what we can see is that around 1 in 20 have severe ongoing pain, and it doesn't matter what we do to them, they just continue to have severe ongoing pain. Obviously, we have no idea what's going on with these patients. About 20% recover completely. For some, it goes very quickly, and for others, it takes a little bit longer. But once they say that the pain is gone, they don't have any recurrences, they don't have any flare-ups. But for most people, for 2 out of 3 people who seek care for back pain, they actually never are completely free of pain, and they have flare-ups of pain. They have good periods and bad periods. So it's a chronic recurrent condition that comes and goes. And it's very important that patients understand that that is normal for people, for many people with back pain. It doesn't mean that their back gets progressively worse because they have a flare-up. It's like having a migraine. A person who suffers from migraine, I have a daughter who suffers from migraine, and it's a very unpleasant condition to have, and it can be debilitating for a few days. But she knows that her brain is not getting gradually worse for every episode. Just like for every episode of back pain you have, it doesn't mean that your back gets weaker or worse and you're going to end up in a wheelchair. It's the natural course of the condition you're studying. And there are many chronic conditions that behave like this. And back pain is one of them in 2 out of 3 people. So patients just need to understand that so they don't get upset and do irrational things and decide to go for more radical therapies when they have a flare-up because they lose faith in their own back. People with very strong backs, elite athletes, can have this pattern. We now know from new research. So the course of back pain is also not what we thought it was. What about treatment? Well, treatment recommendations are also shifting with new research. And this is the front page of the new WHO guidelines for non-surgical management of chronic primary low back pain in primary care and community settings. And I suspect that's where most of you will be practicing. And I want to alert you, if you will, to this term, chronic primary low back pain. That's actually a term that's been introduced with the ICD-11 disease classification, and that will be replacing the terminology non-specific back pain. In ICD-11, pain has been recognized for the first time as a disease in itself with its own code. So you can have primary low back pain, meaning the pain in your back is your disease. There are other codes for disc herniation or radiculopathy or spondyloarthropathy and spondylolisthesis, all kinds of things you can have wrong in your back. But for most people who don't have a structural explanation for their back pain, those we used to call non-specific back pain are now diagnosed with primary low back pain. So you can have chronic primary neck pain, chronic primary knee pain, where the pain in itself is the diagnosis. And here's the report itself is around 300 pages long, and there are many appendices. And I mean, if you're really interested, it's freely available at the WHO website. You can just download it. I was part of the guideline development group. It took 3 years to develop this. It was a huge amount of work, but it was also very rewarding. And this is, in one snapshot, a quick guide to what we recommend here. In this column is what we do recommend. And in this column are things that we assessed as part of in the guideline development group, but we decided that these interventions should not be used as part of routine care. So here, structured and standardized patient education and or advice, and I'll talk a little bit more about that, what that means later. Physical interventions, structured exercise therapies or programs, needling therapies, spinal manipulative therapy, massage, and if, especially for elder people, if they needed a walker or we call them these things, or a cane or a stick or something, they should be provided for them. Psychological interventions, and none of this is really surprising. This is more or less what we expected. We've been seeing that in guideline recommendations over the past 20 years, that these things have been recommended. Really where the big difference in this guideline is when you look at medication and medical treatment of back pain. We only recommend, of the drugs that are commonly used for back pain, non-steroidal anti-inflammatory drugs. And we only recommend it in people under 60. So that's why it has this gray frame around, this gray background, is because we only recommend it for younger people, and we only recommend it with careful consideration and only for a few days. All of these other types of medications that we see over here, that very many brand names and types, these are more the classes of drugs here, we recommend against. And these are all drugs that are used or have been used to treat back pain. So really, there's been quite a massacre, if you will, on medical pharmacological treatment for back pain. And that's causing a lot of problems or raised eyebrows in health systems everywhere, because the pharmacological treatment of people with pain and back pain is probably the most common form of treatment that we have. And then, of course, multi-component biopsychosocial care for people who need that. And just following up on the paradigm shift in relation to medication, I'm just quoting this editorial that was in the British Medical Journal a couple of years ago, written by Martin Underwood, who was also in the guideline development group. He's a professor of primary care at a university in London. And they wrote that overall drug treatments are largely ineffective for back pain and osteoarthritis, and they have the potential for serious harm. We need to work harder to help people with these disorders to live better with their pain without recourse to the prescription pad. And this is really, I think, a very radical statement. And this is also framing exactly what we are trying to do in Gladback, trying to help people live better lives with their pain. And the data and the research is showing that indeed we can do that. If we look at exercise, that's a recommended intervention. You might know Jill Hayden. You should be very proud of her. She's a Canadian professor from Nova Scotia. She is the world's leading expert in the clinical effectiveness of exercise. And I'm not going to go through this whole slide, but what it shows is that one, without a doubt, exercise is an effective intervention for people with chronic back pain, but the effect sizes are fairly modest. It's not a miracle cure. And if you look at the individual studies in relation to pain intensity and functional limitation outcomes, these dots indicate the variation in estimates from the different studies. And there are now over 500 randomized clinical trials looking at the effectiveness of exercise for chronic back pain, meaning that the estimates are a little bit all over the place, but when you add it all up, there's no doubt that exercise is an effective treatment. But it's also important that people know it's not a miracle cure that will for most people, it's not a miracle cure that will make their pain disappear. Exercise works better when it's higher doses, higher intensity, and longer duration. It works better if there's a co-intervention. Most commonly in studies, it's patient education. And if you look at the effect size of exercise, it's more or less equal to the effect size of manual treatment. So you can still use, it's not part of glad back, but you shouldn't be afraid to use manual treatment. If the patient has a flare-up, if the patient finds it helpful and useful, that can be fine. It's not part of glad back because we focus on making people more independent of treatment. But don't forget, just like we say in the WHO guidelines, manual treatment can be helpful for people with back pain. If we look at systematic reviews of patient education, we can see that they are most effective if they are delivered with physiotherapy, other physiotherapy care. And most commonly in the studies, it's structured exercise. And if you add patient education to physiotherapy care, you get more sustainable effects for physical function and fear avoidance. We can see a clinical effect of patient education on its own, but if you add it to structured exercise programs, that's what most of the studies have done, you have an additive effect. It works better than exercise alone or patient education alone. There's an additive effect of them, and that's why we have this integration of patient education and structured exercises in the glad back program. And the patient education, as we say in the WHO guidelines, aims to improve the understanding of the pain experience for a person with chronic primary low back pain and help guide their self-management and well-being. The last point on this slide is very important because we write that it's distinct and separate from education and advice provided by a health worker to a person with chronic primary low back pain as part of the clinical encounter. What does that mean? It means that it's different from the usual dialogue you have with the patient. It's the structured dialogue that is targeted to that particular patient. And it's an intervention in itself. And we need to start thinking about patient education as an intervention in itself. You might have heard about the RESTORE trial. I was part of publishing that a couple of years ago. We assessed cognitive functional therapy compared to usual care. And cognitive functional therapy is a type of therapy where it's highly specialized therapy, a one-on-one therapy. But what you do is you take the individual, it's for people who are very chronic, and it has greatly inspired the way we think about back pain, and it greatly inspired the glad back program. But what you do in cognitive functional therapy is that you give highly individualized patient education, and you use exercises to challenge the patient's unhelpful beliefs and their beliefs about things that they cannot do that are mostly irrational. And you work with the patient over a series of sessions, and there's been previous studies showing that it can be helpful. In our trial, comparing it to usual care, we could see that the cognitive functional therapy groups the difference between the cognitive functional therapy groups and the usual care group was very large, much larger than you normally see in trials of these very chronic patients. So it's a proof of concept trial. Here's another way of communicating it. With usual care at 3 months, about 20% of the patients had a clinically relevant improvement, whereas a much larger proportion with cognitive functional therapy, and the same after 1 year. And this figure over here shows the cost effectiveness of the intervention. And if you're not used to looking at these cost effectiveness studies, I can just tell you that if the estimate for the intervention is in this lower right-hand quadrant, it means that it's both better than the comparison and it's cheaper. So having patient education integrated with exercises compared to usual care is both better and it's cheaper to do. So that has been a very impactful trial. We've also worked with patient education in digital interventions. And this is an area where we're also witnessing a paradigm shift, that we're seeing an increased use of digital interventions in all types of healthcare, but also in relation to back pain. We were giving a very large research grant by the European Union, over 5 million euros. That was a very good day when we received that grant, to develop an app that has an underlying machine learning mechanism or artificial intelligence mechanism. So depending on what the patient tells the app, they get very personalized educational messages and advice about physical activity and specific back pain exercises. And they can then interact with the app. And the more they interact with it, the better they get to know the patient, and the better and more personalized the advice gets. And what we did in the trial was that we randomized about a little over 450 patients after they had completed a course of treatment or care with physiotherapists and chiropractors. And the one group were giving access to a website with guideline-based information, and the other group received the Selfback app on their smartphone. And what we could see was that, yes, in the group that received the usual care, the website, there was a significant proportion who had a clinically relevant improvement over the following 9 months, which is really great that patients tend to continue to improve. But adding this digital interventions, statistically significant, and then quite a few more people achieved a clinically relevant improvement in their back pain. And this is cheap, and there are no known side effects of using interventions like this. So it's just a good example of how we can use digital interventions to maybe boost the effects of our treatment. And we actually developed this app in the same period that we developed the Glad Back program. And the content that's in this app is exactly the same that's in the Glad Back program. So e-health or digital health is something that we will get more used to moving on. And I think we should embrace it, because whether we like it or not, it is coming. I think it can extend the effects of our consultations. It can help us to keep the patients engaged. It can have a public health impact. If the patient allows you to, that they can do that in the Selfback app. The clinician can actually see how the patient interacts with the app, and it can help monitor the course of the patient's back pain, and it can also potentially help the clinician give better advice to the patient. So instead of creating a great distance between patients and clinicians, I think if we do it right, digital health can create a better and closer connection between patients and clinicians, and that's at least my hope. So the paradigm shift, the overall paradigm shift in back pain care, is that self-management is at the core of care. And why is that important? Well, it's because the patient spends very, very little part of their time in your clinic. Most of the time, they're not in your clinic. You can do good things in your clinic, with your treatments, whatever you do. But it's about shifting from what goes on in the clinic to what goes on outside of the clinic. And it requires a much stronger and closer dialogue with the patient. So being a clinician these days is different from back in the day when you just practiced in your clinic and healthcare workers were in the healthcare system and people came to the healthcare system to get fixed. Now we are engaged in self-care, advising people about self-care, and that's healthy lifestyle, even advising patients who are not sick yet. These are things like remember to brush your teeth and don't smoke and don't drink too much and remember to exercise and all these kind of things. And maybe also pain education, that pain is quite normal. Pain doesn't necessarily mean that you have an injury in your back or in your body. That's good to know before you have pain. How do you live well with a chronic disease? We just learned that 2 out of 3 back pain patients will experience some level of pain or flare-ups or recurrent episodes of pain. How do you deal with that in your life? Just like how do you deal with having a diagnosis of diabetes or COPD or some neurodegenerative disease? What can you do yourself to live a better life? And what do you do when you have symptoms? What are the actions you can do that reduce your symptoms? And of course, healthcare is part of that. And seeking your care is also part of that. When should patients seek healthcare and what type of care should they seek? We need to empower patients about this, or they will start to make irrational decisions and seek more radical types of care. And we are seeing that in abundance in high-income countries. At least we are in my country, and I know it's the same in Canada, and in particular in the big country south of your border. Now, a lot of the information I have talked about, you can find in these 3 papers that I was part of publishing in a journal called The Lancet. It's some years ago we published them. But I think they are still fundamentally really sound. We are working on updating them. It's been 6 years since we published them, but the fundamental research, the core messages are the same that comes out of these papers. And the editor of The Lancet, when we published them, this was his takeaway message. Richard Horton is his name. He said, a major challenge will be to stop the use of harmful practices while ensuring access to effective and affordable healthcare for people with low back pain. I think that was what Greg was alluding to in his introduction. I'm not sure now, 6 years later, that we reached that point, but we have much more awareness of it. In 2022, we were asked to do a review for the journal Pain. We say, well, what has happened since 2018? And the reason why I'm showing you these papers is because they're all open access and you can find them online and you can read them at your leisure. So this was my quick update about current understanding of the concept of back pain, about the course of back pain, about diagnosis, about clinical management, about the public health thinking around back pain. And we've now reached gotten the attention of the very highest organizations in the world and in many countries. And there's a great realization or consensus that we need to work together to provide better access to safe and effective care for people with back pain. And GladBack is one contribution to that. So I hope you have enjoyed the talk. I hope you have a very good course, a very good weekend. And thank you for once again inviting me to give this talk to GladBack Canada. Thank you.
Thank you so much, Jan. Lots of thumbs up and clapping, and thank you for, it's amazing how much things change so quickly, really. We were talking in our sort of smaller groups about even our training we made for physicians a couple of years ago. Some of this has changed since then. So thanks. We're lucky to have one of the authors from the WHO guideline. And is there any burning questions for Jan, or should we let him go back to his garden?
It's almost wine o'clock here.
Right. The garden tools have to go away soon, and the wine glasses need to come up. Super, super. Oh, there is a question about, is the app available to use?
Yeah, so that's a very good question. Many people ask that when I give this talk. Part of the grant from the European Union was that this app should be commercialized because, as you might know, Europe is lagging behind North America in the tech business area. We haven't really seen any large tech companies in Europe other than Spotify, I think. So the European Union wants to create more employment in tech. And so anyways, it's now owned by a company, and it's not available in your app store or other places. What they're doing is they are selling it to health system administrators and insurance companies. And we are seeing, for example, the NHS in the UK have bought the Selfbag app, and they are making it available as a prescription to people who seek care in the NHS for back pain. If a physiotherapist said, well, this app could be useful, they get access to the app, and the NHS pays for it. So you can't download it yourself. It's prescribed by doctors, physiotherapists, and in some cases also chiropractors, for example, here in Denmark. So yeah.
Super. Thanks for that, Jan. And I put it in the chat too, but we have 2 pilots going on in Alberta right now. James, who's teaching this weekend, is doing one with, there was a few licenses given to the Alberta Chiropractic Association. So, and then we also have this rehab advice line that's a few years old here in Alberta, where people can phone and ask for help for any rehabilitation needs, and they have access to licenses just as you.
And let me just say, I think there are many clinicians who do a really good job with treating back pain. There are other apps out there. There are other solutions. There are other programs that are wonderful. This is just one example that I was involved with. And I think it's just an example of, what can you say, that it can be helpful if you use it right. It's not the only app that will ever be helpful.
Right, right. Thank you so much. Any other burning questions, or should we release Jan to wine o'clock?
Thank you very much, and enjoy the week. Bye-bye.
Thanks, Jan.
See you next time. Excellent. Well, that's great that you got to meet Jan live. Alice is just as engaging live. She couldn't make it this weekend just because some family things came up for her at the last minute. So Sylvia, who's managing our Glad Back account, is just going to queue up the recording. So we'll play that recording. It's about 45 minutes or so. So we'll play that, and then I'll give a little bit of introduction after that. So it looks like she's got it queued up now. Enjoy this next 45 minutes, and we'll see you afterwards. You can put questions in the chat if you'd like. We might, Sylvia, I don't know if it's just me, probably everyone else, I can't hear her audio. So we might need to change your settings on Zoom where it says something like, if you go to audio and then say select a microphone, I don't know, you might need to set it as same as system or something else.
Thank you, Greg. Thank you for inviting. It's always a pleasure to be able to just share a little part of the training course when you are working in Canada. I've been involved with the development of glad back for around 7 years, so it's really a joy to see that such a big group of clinicians now have chosen to spend your weekend on having glad back training, and I really hope you will enjoy it and you will find it helpful in your clinics. Just want to make sure that I share the screen with presentation mode. Is that on?
Looks good, Alice.
Very good. Just a second for me to arrange my screen. Yeah. Okay. We will get a little closer to Gladback during this talk. It is still about background, why Gladback is combined the way it is. So I will introduce now some of the background and outline simply the principal thinking behind the design of Gladback. So don't panic if you start thinking, I have no clue how I can deliver all of this, because that's exactly why Gladback is a structured program with a lot of supportive materials, as Greg just touched upon, that you don't have to remember all the theories and principles behind Gladback. It should be relatively easy to deliver with the materials that we have developed for you. If you want to read more about the principles, it's both in the paper on self-management that Jan just mentioned, but also in the papers that describe the development of GLAD if you are interested in more detail. Greg already introduced that GLAD, and that is both GLAD for hip and knee and for back pain. It consists of these 3 elements. It's patient education exercises, it's the clinician training that you're doing right now, and it's data registration for research. In this part of the course program, I will focus on the patient education and exercises, the patient intervention. What's the background for that part? First of all, I just want to mention that in Gladback, we do not use the Good Life with Osteoarthritis that GLAD was actually originally an abbreviation for. And that's because the Gladback program is not just for people with osteoarthritis. It's for people with back pain and a need for improved self-management. So we simply just say Gladback without the osteoarthritis part. The program, just in short, you will come back to each element during today and tomorrow. It's first the individual session where there's goal setting and some tests with patients. Then we have the theory, the patient education part, and then the supervised exercises, all of it group-based. And then at the end, you will evaluate with each individual patient, evaluate their goals, and discuss with them what's the plan from here. The program was developed for patients with long-lasting recurrent back pain and a need for better self-management. And later today, you'll come back to what's the exact target group and how do you identify a patient who could be a candidate for the Gladback program. So the approach to treatment or to handling back pain in GLAD, what does that look like? The overall thing is about introducing this paradigm shift that Jan talked about. So I think the main thing of that is that it's less about the structural impairments that we have traditionally actually looked a lot for, not only with scans and x-rays, but also in our clinical practice. I was trained to look for reduced movement in parts of the spine, muscle impairment, lack of alignment. And now we know that we help most of people with chronic back pain better with focusing less on trying to figure out what their exact structural impairment is, and rather focusing on how can we help them develop useful reactions to pain so that they're not so restricted by their back pain issues. We see that a focus on structural diagnosis tend to create a lot of confusion and also an expectation of, if you have to find what's wrong and then you can fix me. And if you can't fix me, you're not the right clinician and I will go somewhere else. I guess many of you have seen patients who had also very many different explanations for their pain. And one reason for that is probably that we all try to do our best with a structural diagnosis or finding a structural impairment, but as evidence actually says that that is very difficult to do, it ends out being all of our individual experiences or best guesses, and that tends to be different from one clinician to another. So in the end, patients are just told different things and they don't know how to react to that. But it's also so that if we are to change that, we have to help people. We have also to assist patients in changing their expectations to what can clinicians do to them. Is it realistic to have a fix of their back pain? And that requires that also patients are educated about pain. So we will keep coming back to that. A key element of GladBack is the patient education, and I think it's so important because it's impossible for patients to take on part of self-management and self-care if it doesn't make sense to them. And it's not meaningful that you cannot treat their pain away if they don't understand that the pain is not just about some impairment that you can fix for them. Now, the good news in this is that doesn't mean that you have to learn with the pain as it is, because we know now so much about the pain and how pain the pain experience is developed, that we also know that pain can be reduced even if there's not a structure or an impairment that we can take away, because self-management strategies actually affect both symptoms and disability, also in chronic patients, because pain is affected by not only bodily structures and what's in the spine, but also the way that people react to it, both in terms of behavior, in terms of their emotional reactions, and the way they think about pain. And understanding that very many factors actually play into the pain experience also provide us with a lot of options, or provide people with a lot of options to affect their pain. And that is what we would like to help people understand with GladBack pain, or with GladBack, that you can actually, even if you can't change the spine that you happen to have, and that might be a sensitive spine, you can actually reduce your pain and the disabilities if we can push these different buttons that affect the pain. So self-management is about living a meaningful life with the spine you have, and the bonus is that when you start being able to engage in that, it's very likely that that would actually also reduce the pain intensity, the pain experience. Self-management is very tightly related to behavior change, and we draw quite a lot on theories from supporting behavior change. Much of that is from areas like weight loss and tobacco cessation. In back pain, it might be a little more complex because the behavior change is not the same for everyone. For some people, it's about getting more active. For some, it's about finding different ways to move. And an important role for you is, of course, to try to figure out with the patient what's the meaningful change that is to happen in your life. It can be an everyday life change. It can also be to achieve that everyday life change, you would need to figure out how to change the way you move, the way you use your spine and body. And I think as clinicians, it's very clear to you also that engagement in self-management and in behavior change also is about motivation. And we'll come back to that, or I'll come back to talk more about motivation at the end of this talk. First, I want to revisit this illustration about self-management. And underline again that you as clinicians has an important role to play in self-management, because self-management is not leaving people alone with their health issues. Healthcare providers are to support that development. And if people, they seek care from you, it's probably because they were not in a situation where they were able to self-manage without any support. Traditionally, much of healthcare for back pain has been mostly about the symptom management part. So when people had a flare-up, a bad episode of back pain, they come and see you, and you will, with exercise therapies, manual therapies, maybe pain medication, help people reduce that episode of pain. Now we see the role different or more extended, that it's also about helping people to find out how to self-manage, to maybe avoid some of the flare-ups, but also to handle the ups and downs and everyday life with recurrent or chronic back pain. So there's more to the role, and I also think this means that as clinicians, there's a job to do every time you see a person with back pain, to first try to negotiate or discuss with the patient, what's the target here? Is it episode treatment to just reduce pain for a couple of days, or are we talking about a long-term strategy that can help you manage this over time? If we are talking supportive self-management, we know that strong self-management relies on having knowledge about your condition and management options. It takes some skills. What can I do when I have pain? And it takes the development of self-efficacy for self-management, the perception or the belief that I can actually do something to affect my pain and affect my whole situation. And as long as people don't feel and understand that there are things they can do to affect their situation, their pain, it makes good sense that then there's no reason they would try. So during all of the program, we try to work a lot with being supportive, being again and again telling people that it's good what they try to do, support their initiatives, and support their beliefs in that they can actually handle back pain, and they don't need you next to them in every situation in order to manage. So let's talk a little more about the underlying principles related to achieving the knowledge to self-manage back pain. The knowledge that we would like people to have is much about understanding pain in a way that reduces the fear of movement. We know that many people with back pain, they are reluctant to move, and part of that is a fear towards making things worse. And I'm sure you also recognize that from your practice, that you have people who they stop moving, of course, partly because it's painful, and pain is really just not nice. But also people have been told that I shouldn't do this or that, and shouldn't do comes with some more or less explicit explanation about, because then I will harm my back. So we will like to make people understand that pain is not a sign of damage, and thereby reduce their fear of movement. We also try to explain pain in a way that provides options for change. So like I just touched upon before, because pain is affected by many different things that can be modified, there's also an option to to change the pain experience. And when we understand that back pain is not just about structure, about a degenerated disc, or about some muscle impairment, or about having a big or a small lordosis, or whatever people have for explanations, if we understand, if patients get to understand that it's not just about my structure, that also leaves an option for control, because they cannot do anything about it, a degenerated disc, but they can perhaps do something about other things affecting pain, such as their behaviors, their sleeps, their stress level, and so on. Therefore, when you deliver the theory, the patient education sessions, and in the materials, you will see there are some core or key messages that we keep coming back to. And these are messages such as the back is strong and made for movement. So although that your spine hurts, that is not a sign that it's not strong. And we know that movement actually reduces pain. And that may not intuitively make sense for people, that a harmful or a painful movement can be good. But we know that movement is part of reducing pain, and we know that the structures in the back are strong also when they hurt. I think it's really essential for people to understand that pain does not equal harm. So it's not so that the more pain you have, the more it's wrong in your back. And we will give examples in the patient education to illustrate that. For most people, I think, or for many people we see in the Glad Back program, it actually makes sense that there's not a direct correlation between pain intensity and damage to your spine when they only have it explained. For example, very many people, they have pain that is very different from day to day. And if we talk to them about how would that match a belief that my pain is due to my degenerated disc. Your degenerated disc is the same from day to day. And then people will start thinking, hey, yeah, probably then there's something else to it. And maybe we can identify some of these factors affecting my pain. And that comes to the third point here, that pain is influenced by other factors that you can affect. We keep coming back to also the movement as a part to relieving pain. And then this last statement that action comes before recovery. And by that, we mean that it's, I think for many patients, it would make good sense to first take my pain away, and then I can start re-engaging in daily activities and in movement and in physical activity. But that's just not how it works. We know that for pain to reduce, they have to start engaging in things that they value and in movement. So these actions come before pain reduction. And I think that's sometimes difficult for patients to grasp if they have a picture of something having to be fixed, and then I can come back to my life. All of these elements is something that will be underpinned during the supervised exercises, and you will also know more about that both today and tomorrow, what that looks like. The theory underlying all of these elements or all of these messages is the knowledge around that pain is reduced when fear is reduced and when we have an increased sense of control. And all of that happens through some known physiological mechanisms. It is so that it's not only our pain, the pain experience is not only about psychological mechanisms in a few people who have some extreme psychological component to the pain. Psychological mental mechanisms affects pain in all of us because that's how pain works. And we now know much more about the physiological mechanisms behind that. For example, there's a bunch of knowledge that can illustrate that the way that expectations, fears, catastrophizing about pain, when these things are reduced, that affects pain through some of the same connections in the brain as if you have opioid pharmacological treatment. So there's really a physiological explanation to why reducing fear and increasing sense of control and self-efficacy literally reduces the pain intensity. We also know from literature that when treatment they have a positive effect on daily function, works well on improving daily function, it's partly because they change people's understanding of pain and increase their self-efficacy. And that goes for both physical and more psychological treatments, that part of the mechanisms why they work is that they change the perception of restrictions or the way that people consider their condition. And actually not that much about having stronger muscles or better alignment or things that we previously believed more that was the reason why exercise therapy, for example, works. We can't really show that people, they improve from exercise because they get stronger, more than it's because they start thinking differently about pain and they learn to react differently to pain. So that is perhaps one of the most challenging things to shift in the minds of many clinicians, that it's not so much about us finding a way that people can exercise so that they affect their muscle building the best way or their building of core strength the most effective way, but it's more about instructing exercise in a way so that people, they find movement patterns that works well for them and feels right for them, finding ways that feel good for the individual person. So this was a little about the knowledge, and I started talking about that self-management also takes some skills, and there are some well-described techniques that we might not think so much about, even if we use them, that actually are shown to improve people's ability to engage in self-management. So things like goal setting, problem solving, and behavioral experiment, I'll come back to each of them. They are techniques to help people take control of their own care and situation, and ways to help people identify the how they can work with their movement or their limitations also when you're not next to them, because they develop a skill set for identifying their problems and solutions. In the first session of Gladback, you start with goal setting, and working with goals is it's actually the place where you establish that that now we're working towards your goal, and the goal is not about what you doing some miracle to a structure. It's about them being able to engage in something that they would like to do. So goal setting is about identifying what's important to the individual patient, not about what's wrong with you. And it's an option for talking about what is actually the desired change, what would make a positive difference to you, and what's in the way for that. And starting the conversation about when you cannot do what you would like to do in your everyday life and what you used to do before. To what extent is that about physical impairment, that you're not physically able to do it, that the pain is so intensive that you couldn't do it in any way, or and to what extent is it also about your understanding about what would happen if you do this, your fear about would it be worse next days, and the way you approach the problem. Could there be something to gain from changing the behavior, the way that you go around this your goal? So I think it's really important to set aside some time for goal setting, to go into this talk in the first session. Help people to reflect on why it's important for them to make a change, because that's what would carry their motivation during the program, and also how to get started. And in Gladback, it's a conversation that should hopefully motivate them for seeing the potential value of starting the program with the patient education and engaging in exercises. But it could also be that they say, hey, I'm actually motivated to go home and start going for a walk every second day until we start the program. Problem solving is, am I like a slide behind always? Problem solving is often in exercise delivery or in instructions of exercises. Problem solving is often about, or have been, some of you have probably changed that to some extent over the last years, but I guess many have been trained in that when you instruct exercises, the problem solving is very much up to you. You define the problem, you observe how people move, you tell them how to change that in order to move more correctly. In Gladback, we try to do more of a engagement with patients for them to engage, to be part of the problem solving. So identifying what's the problem with this movement. What do you feel? What do you experience? Is that like something you have issues with in your everyday life? And what's the usual strategy, or what's the strategy you use right now in the exercise class? How do you try to do this? And then discuss, if that doesn't work, would there be some alternative strategies? Could you try to move differently? Could you try to do the movement quicker or slower, or in a slightly different direction? Could you stand or sit slightly differently during the movement? And the thing is that you as a clinician have a very hard time to telling people what would work for the individual, because they have to feel that out and figure that out. So they will have to try alternative strategies and evaluate what works, what didn't work, and simply figuring out what feels good for me, and also understand that this is something they can consider over and over again, because your body doesn't work the same way every day. You would also see that in Gladback you work with what you could describe as behavioral experiments. It's not as fancy or tricky as it might sound. It's simply about challenging the thoughts and understandings that people have about why they cannot do what they would like to do. And we get some options during the exercise classes to challenge that. So if we have patients that have a sense that there are things that their back cannot do, and of course there are things that some backs cannot do, and young backs can sometimes do something that older backs cannot, and that's just part of life. But there are also things where we would say, is it really so? What's it based on? What's your experiences? What's your thinking when you say my back couldn't do that? And could there be an alternative to that? It could be that this is painful, and my thinking is that my back cannot do or should not do something that could provoke pain. An alternative view could be, when you have had the theory sessions, that this is a sign of my alarm response going on, or it's a sign of that I have for a long time started not trusting my back, and this is really I cannot do it because I do not trust that my back would do it. And you could provide some alternative to a belief that the back is weak, or that it would be harmful to do a movement, and then set up an experiment where people try some of it, part of at least what they thought they couldn't do, and also try to evaluate that maybe during another perspective, seeing that, yeah, my back can actually do this without breaking down. It can do this without being much more painful afterwards. It might not do it without any pain or discomfort, but the belief that I had generated that it couldn't do it at all turned out to be wrong. And I hope you'll get some opportunities to do some of these challenging people's maybe long-learned beliefs about what their backs can and cannot. So the last component to talk a little about here is motivation. I'm sure all of you have some patients where you think, I simply can't help him or her if he or she isn't interested in helping themselves. I have tried all kind of things. We have discussed how it's important to engage in physical activity, how this person would have to engage in some exercises, some movement, but it never happens. So motivation is a true challenge, I think, in all kinds of treatments that you cannot do to people, but they have to engage in themselves. And we know from theories and from many areas of chronic disease and also of other motivational behavior, that motivation has to come from inside. And for people to build motivation from inside, they have to develop competence, the feeling that I can do this, autonomy, that I do it for me. It's not because my physiotherapist or my chiropractor or my doctor tell me to do something. It's really because it's meaningful to me. And lastly, I'm not alone with this. I feel some relatedness. I feel support. And these parts are also things that we hope are to some extent built into the Glad Back program, but also, of course, something that is only carried through if you are aware of them. Building competences through the supervised training, through the problem solving, people's experience of success during their training, and also being validated that it's correct what they feel. You trust that when they say they're in pain, they are in pain. We help them to understand the symptoms so they feel competent in relation to understanding their disease. Autonomy is built through individual goals. I pursue my own individual value-based goals. I don't do exercises in order to get stronger or aligned or because my physiotherapist tell me to. I do it because I would like to play with my children. I would like to see myself getting older and physically fit. I would like to be able to be in my workplace that's important to me. We also know that autonomy is felt when you have choice and you have your own solutions, and that's also a reason why we are not very directive with the exercise supervision. We don't tell people you have to move this way, but help them to find the best solutions for the individual. And lastly, we have the group-based therapy where people, they say, it's really nice to see it's not just me. Other people experience the same kind of symptoms and the same kind of challenges in their life. And all of these things are also things that feed into building self-efficacy that we know is part of the mechanism behind effective treatments for back pain. Motivation is something that is supported or developed very much through communication also. And I'm sure you have the communication skills from your practice that feeds directly into Gladback, and are aware that things that are important to patients and to motivation, things like listening, show interest and validate. Be sure that people know that you trust what they're saying and that you're actually truly interested in helping them. Avoid being too instructive, avoid using a lot of you must, you shouldn't, you must avoid it, so on. Ask about people's thoughts, feelings, experiences. Don't be afraid to ask about things you can't do anything about. Showing interest, trying to understand people is better than avoiding knowing things you couldn't do anything about. And avoid contradictory information that frustrates people. If we say in the patient education the pain is not a sign of injury, then it doesn't make sense afterwards to say avoid twisting your back if it's painful. That would signal that that is injuring people, and it's the kind of messages that too many people with back pain they have experiences with. So coming back to this illustration of pain, that thoughts, behaviors, feelings, and symptoms interact in the pain experience. And what we do with Gladback is trying to, of course, recognize that makes back pain very complex, and it also makes your role in back pain treatment very complex. But the good thing is that it provides options for affecting pain on many different levels and in ways that people can engage with in themselves also. So to sum up, we want to use explanation that provides options for control, want to create during all of the program a sense of safety, empower patients to find their own solution, and focus on opportunities instead of correcting mistakes. Always with the intention for people to build self-efficacy and build inner motivation for engaging in an active management strategy. So just before I end, I think I'll just mention a few Danish results from the Gladback program. First, from the pilot study, I just wanted to point to that we recruited patients in the same clinics before they started the Gladback program and after. And one particular change was that people with back pain before the Gladback program, they only 1 in 3 or a little more than 1 in 3 said that they had really patient education or thorough information about the situation, whereas that was 9 out of 10 with the Gladback program. Also, more people had exercise therapy after introducing Gladback, but the really big shift was the perception of the extent to which they had their pain explained. As Greg also mentioned, when we look at the patient profile, it's generally people with very long-lasting pain. They have had pain for years. Many of those entering the Gladback program, they have had treatments before. In Denmark, it's almost 8 out of 10 that have been in treatment for more than 4 weeks when they enter the Gladback program. They have moderate to severe pain intensities. They have mainly moderate levels of disability. Not many in Denmark are on sick leave. It's a working population, and that is what we would like them to stay with. But many people in the program, as with back pain in general, have comorbidities. So there are good reasons other than the back pain for many of these people to become more physically active, because that would also help or may be secondary prevention in relation to things like cardiac diseases and diabetes and other common comorbidities. If we look at the change in pain intensity, I think one interesting aspect was to look at people in groups of to what extent they had been in training when in treatment already when they started the Gladbach program. And here the different colored lines are people who have been in treatment for different time periods before they start. And we observe that even those who have actually been in treatment for more than a month before they enter the program, they almost have the same level of pain reduction when entering Gladbach. And one thing that's also really good to observe that we don't see with all kinds of treatments is that the improvement that they obtain during the program is more or less sustained during a whole year follow-up. It looks like they gain something from the program that they can use over time also. Pain experience is, of course, not only about pain intensity. I think it's also important that people, it seems that they start looking differently at the pain. And here, just from a couple of interviews and some qualitative studies, where we have one person, he said, you can challenge the pain and do something despite it. I have taken that to heart. And that was somebody who really wanted to be physically active. He did some training and he had stopped that because of back pain. And with the Gladbach program, he didn't get rid of pain, but he had understood that you can challenge it and you can do something despite it. And that made a difference to him. Another person said, now I can work with my back pain differently than if I didn't understand it, because I would be worried to do anything, fearing that I might make it worse. Again, about understanding pain, it's not that this person says that now I have no back pain anymore, but I can work with it differently. And that's a positive difference to this person. Here are disability scores. And we see that it's people with the most disability when they start the program that change the most, and that makes sense that if you don't have a lot of disabilities, at least on this score, you won't change much. But the green line are people who would be categorized as being severely disabled when they enter the program, and they have improvements that corresponds to moving from a severely disabled group to a moderately disabled group. So that is probably an important difference to these people also. Similarly with fear avoidance, the part of the sample that really have strong fear avoidance when they enter, they change that a lot during the program. So we observe that people, they benefit in different ways from Gladbach. It's not everybody that respond on pain. It's not everybody that respond on fear or disability. It seems that people have that the same program affect different outcomes in different people. And of course, there are also patients who do not respond on any outcome, as it will be with any program that we could suggest. On a scale from 0 to 10, on average, they would achieve the girls up to a 6.6 during the program. And we also see that some people, they actually have a relatively high goal achievement without changing their pain and disability a lot. So there's something else to it that people value. And around 8 out of 10 would say that they are satisfied or very satisfied with the program. If you want to read more, there are a number of papers, more than these, published on Gladbach and on the Danish Gladbach homepage or website that you see the URL for here. There's also an English site to it, and where you can find all the publications that we have been able to publish this far, and we keep adding to that list. So with that, I would like to thank you for listening, and I will wish you a great course during the weekend. So I really hope you'll enjoy. I hope you will learn a lot and that you would be very motivated for using GladBack when you are back in your clinics on Monday.
Well, thanks everybody. Is my audio okay? Super, thanks. I actually have to coach hockey over the lunch break, so I'm a little bit echoey. I'm in the ref room right now at the rink. And I see Aaron's outside. See, everybody's in different spots. This is the beauty. Tomorrow you'll see that our instructional team will all be together at the university. So that'll be great as well. So my presentation is about 20 to 25 minutes long, and then we're going to take a 15 to 20 minute break. So I'll share my screen, and I know we had some people who were only joining for these two presentations. So what I want to capture is I wanted to capture that we get some feedback. So just a little bit of a thumbs up. Can you see the screen that asks about getting feedback? Super. So especially if you're leaving now, if you could quickly scan and do the evaluation form, even if you're not leaving, it would be great to get some feedback. We've partnered with the Physician Learning Program at the University of Alberta. So they offered these first 2 hours of the day